This is Dr. Julie Huffmeyer with our open anesthesia intraoperative TEE case of the month for February 2012. Each month we feature an operative case which teaches or emphasizes an important aspect of basic intraoperative TEE. Our patient for this month is a 54-year-old man who presented to an outside hospital with 1 week of chest pain and severe fatigue. His past medical history was fairly uncomplicated and consisted of hypertension, insulin resistance treated with exercise and diet control, and dyslipidemia. The only medications he was taking prior to admission were fish oil and a statin drug to reduce cholesterol. The nature of his chest pain was that he had first developed left infraclavicular chest discomfort a week prior to admission while swimming. The pain was intermittent, occurring both at rest and with exertion. He continued to exercise every day as was his usual practice, and a few days prior to admission he ran 10 miles as he is a marathon runner. The next day he was unable to run due to fatigue and chest discomfort, but walked instead. His family noted his face was purple and he was short of breath with chest pain. He was brought to the emergency department and his EKG showed an acute inferior wall myocardial infarction with Q waves noted in the inferior leads. He suffered cardiac arrest in the emergency department and was taken immediately to the cardiac catheterization lab. His cardiac catheterization revealed multiple vessel coronary artery disease with total mid-occlusion of the right coronary artery, 60% occlusion of the left circumflex artery, and 80 to 90% occlusion of his mid-left anterior descending artery. He had bare metal stents placed in all of these arteries and was sent to the intensive care unit with a thorough revascularization. 8 hours later, however, a new loud systolic murmur was noted, and transthoracic echocardiography showed a prominent ventricular septal defect in the inferior portion of his interventricular septum, with right ventricular dilation and severely depressed right ventricular function. He was emergently brought to the operating room for surgical repair of his ventricular septal defect. This is the transthoracic echocardiogram from the outside hospital with the chambers labeled as noted. Note the large septal defect between the left and right ventricles. This is the same view as before from his transthoracic echocardiogram with color flow placed across the ventricular septal defect. Clearly there is flow noted from the left to right ventricle. This is a still image from his transthoracic echocardiogram measuring the ventricular septal defect size. Here it appears to measure 1.9 centimeters. Ventricular septal defect complicating myocardial infarction is uncommon, with a reported incidence in the pre-thrombolytic era of 1 to 2%. It occurs most commonly and typically in the first week after a myocardial infarction. Average time from symptom onset of myocardial ischemia and infarction to VSD formation is 3 to 5 days. The GUSTO-1 trial studied post-myocardial infarction VSD in the thrombolytic era, as previous studies to it had been small and done before thrombolysis and revascularization were standard of care. GUSTO-1 stands for Global Utilization of Streptokinase and TPA for Occluded Coronary Arteries. It enrolled over 41,000 patients from multiple centers in different countries. From this trial, out of over 41,000 patients enrolled, only 84 had post-infarction VSDs. That's only 0.2% of the population. Patients were found to be more likely to develop post-infarction VSD if they were older age, female gender, hypertensive, without a history of smoking, and had higher Killip class, which is a classification similar to the New York Heart Association class for patients having had a myocardial infarction that classifies patients based on signs of heart failure. Angiographic findings were available for the majority of patients with VSD in the GUSTO-1 trial. Patients with VSD were more likely to have the left anterior descending artery occluded as the infarct-related artery, have multiple vessel coronary artery disease, and a lower ejection fraction. Patients with VSD after myocardial infarction in the GUSTO-1 trial were more likely to develop shock states and congestive heart failure. They also had significantly higher mortality at 30 days and 1 year. Patients treated surgically had lower mortality at 30 days and 1 year as compared to those treated medically, but the mortality remained in the surgical group at 50% at 1 year as compared to 97% for the medically treated group. The pathophysiology of ventricular septal defects involves sudden severe myocardial ischemia that continues to infarction in a coronary artery territory. This infarction progresses to extensive myocardial necrosis and the VSD then develops. Patients with inferior myocardial infarctions progressing to ventricular septal defects tend to have a worse outcome. Their VSDs are complex, with multiple irregular and variable interventricular connections, often involving the inferobasal portion of the septum. These ventricular septal defects are difficult to approach surgically and are associated with right ventricular infarction and dysfunction as well. This is the transgastric basal view with the mitral valve leaflets noted within the left ventricle for our patient. It is especially helpful to look at this view in order to see the large VSD near the top of the scanning sector. It is labeled as VSD. Thus, the location of our patient's VSD is in the infero-posterior portion of the interventricular septum at the basal level, corresponding to severe sustained myocardial ischemia and infarction of the inferior wall due to right coronary artery occlusion. This is the transgastric basal view of the left ventricle, this time with color flow Doppler used to illustrate the flow of blood through the ventricular septal defect from left to right ventricles. This is a graphic depiction of the transgastric mid-papillary short-axis view as would be seen on TEE. The left ventricular walls are labeled as septal wall, anterior wall, lateral wall, and posterior wall. In the areas between each of the walls, the description of the wall is as follows. The anteroseptal wall is between the anterior wall and the septum. The anterolateral wall is between the anterior and the lateral walls. The posterolateral wall lies between the lateral and the posterior walls, and the posteroseptal wall is between the posterior and septal walls. It is not uncommon for the posterior wall to also be referred to as the inferior wall. The coronary artery distributions of the myocardial walls are as follows. The anterior and anteroseptal walls are supplied by the left anterior descending artery. The lateral and posterolateral walls are supplied by the left circumflex artery. The posterior and posteroseptal walls are supplied by the right coronary artery. This is the mid-esophageal four-chamber view at 0 degrees. The chambers are labeled as noted. The ventricular septal defect is not readily apparent in this view, although the interventricular septum appears as if there's dropout or maybe a defect in the basal portion near the anterior leaflet of the mitral valve. This is the same mid-esophageal four-chamber view at 0 degrees with color flow Doppler placed across the mitral valve. There is no mitral regurgitation noted. This is a modified four-chamber view in the mid-esophageal location at 30 degrees multiplane angle, with color flow placed this time across the septum with blood flow noted through the basal inferior septum, indicating the ventricular septal defect. At the time of surgery, the posterior-inferior ventricular septal defect was noted to be the size of a quarter, but did not involve the mitral valve apparatus. The defect was patched with bovine pericardium. An intra-aortic balloon pump was placed to facilitate weaning and separation from cardiopulmonary bypass. The patient has had a long, difficult postoperative course that's been complicated by renal, respiratory, and biventricular heart failure. This is a post-bypass view of the ventricular septal defect repair in the mid-esophageal location in the four-chamber view. Some air bubbles are noted to be passing through the left atrium and left ventricle, and this de-airing during weaning from bypass is normal. The air bubbles appear as echo-bright fireflies floating through the left atrium and ventricle. You get a sense from the bright white area on the ventricular septum that this is the patched area where the VSD had been. This is a transgastric view of the bovine pericardial patch that was placed to repair our patient's VSD. In this view, the left ventricular outflow tract and aortic valve are noted as labeled. This is the same transgastric view with color flow placed across the new VSD patch. The repair appears to be intact with lack of blood flow through the defect patch. In summary, ventricular septal defect complicating myocardial infarction is decreasing in incidence but remains a devastating complication with high mortality after both surgical and medical treatment. Transthoracic as well as transesophageal echocardiography are helpful in the diagnosis and repair of ventricular septal defects.